Hi, my name is Jasmine Lewis Martin, and this is my 45-minute presentation on obstetrics and neonatal care. So, obstetrics is such a vast topic to talk about, right? So, I've narrowed the material to focus on pre- and post-delivery care from both the mother and the baby. Here's today's objectives, starting off with the cognitive domain. The student should be able to use anatomical terminology to identify structures within the gynecological system. Assess and provide care to the mother immediately following delivery of a newborn. Along with that, they should be able to identify pre-delivery emergencies, state the steps to assist in delivery, discuss the steps in delivery of the placenta, list the steps in emergency medical care of the mother post-delivery, and summarize neonatal resuscitation procedures. Continuing with the cognitive objectives, the student should be able to assess and provide care to the neonate immediately following delivery. Explain how to measure essential vital signs including pulse rate, color, and respiratory effort. Discuss APGAR scores, including how and when to obtain them. Formulate an APGAR score based off of given examples in the presentation. For psychomotor, the student should be able to demonstrate how the provider's own initial response, such as emotional, during delivery and post-delivery, can either positively or negatively impact the patient's trust. And lastly, for the affective objective, learners will value the importance of cooperation between provider and patient during delivery. The overview includes how to integrate assessment findings with principles of pathophysiology and knowledge of psychosocial needs to formulate a field impression and implement treatment disposition plan for the patients, both the mother and the baby. Here's the given outline I've formulated for the presentation. So here in the presentation, you will see that there is a review of anatomy and physiology of their female reproductive organs. We're going to discuss maternal and fetal physiological changes after conception. We're going to discuss pre-delivery, normal delivery, and post-delivery procedure for mother and neonate. We're going to calculate APGAR scores based off of 4 examples in the presentation. We're going to talk about complications for both the mother and the neonate. So in summary, the care of expectant mothers and infants often causes fear and anxiety to the pre-hospital care provider. It is important to maintain a calm and relaxed manner when dealing with a pediatric patient. Anxiety from lack of experience with treating children, as well as a fear of failure. Infrequent encounters with OB emergencies can cause a lack of confidence in the provider. So continuing to educate ourselves, we resolve those issues through confidence. So let's talk about female reproductive system. We're going to take a look at the internal structures. So as we see on the slide, the ovaries are female sex glands located on either side of the uterus. We have the uterine fallopian tubes. They're 4-inch long tubule connected to the ovary and the fundus, or what we call the major part of the uterus. Speaking of, the uterus is a hollow muscular organ. Its function is to receive the egg cell from the ovary, and it's being carried from the fallopian tube. And in the uterus, it is a place used for implantation and nourishment during fetal growth. It also aids as an added protection to the growing fetus. It aids in labor and delivery. The cervix is a lower, narrow end of the uterus that connects the uterus to the vagina, or what we call the birth canal. Its function is to estimate the level of dilation of the fetus in the birth canal before birth. The vagina, the lower part of the birth canal. It serves as the exit route for the fetus. Now here is the overall structure of the female reproductive system. If we look at the tubule, it's very small in diameter, similar to the diameter of a coffee stirrer. And on either side of the uterus, we have the ovaries. So from the ovary, the egg cell will travel down the long tubule and enter the uterus. And in the uterus, it should implant on the wall. So now that we know what the internal structures look like, let's take a look at the external structures. Well, the main structures, that is. Those are the vagina opening, where the fetus exits the body, and the labia majora and minora that makes up the external skin folds. We have to know what both the internal and external internal and external structures look like to get a better idea of what we may encounter during those types of calls that involve the female body and childbirth. So I've seen in the field that whenever I'm encountered with a female patient and she makes aware that she is pregnant and they're in the first trimester and they're having lower abdominal pain. So in my mind, I'm thinking that there's some type of implantation complication. Now, the incorrect location site is called an ectopic pregnancy, and more than 90% of ectopic pregnancies occur in the fallopian tube. Now, in the back of the ambulance, we're unable to confirm if it's an ectopic pregnancy, but we always have to assume with a female in the childbearing age and that they're pregnant, we have to think that they have an ectopic pregnancy, if not a normal pregnancy, and we have to assume that there are some type of complications with it. So, going back to the previous slide, when the egg leaves the ovary, it's carried down the fallopian tube and is supposed to implant in the uterus. But if it doesn't, if it doesn't implant in the uterus lining, that's what we call an ectopic pregnancy or incorrect location site. Now, the tubule can burst or rupture and cause major internal bleeding, nerve damage, infection, and death. Here's a diagram where the majority of the ectopic pregnancies occur. Now, if you look at the fallopian tube, which we just talked about, where more than 90% of the ectopic pregnancies occur, we see that there are 4 different sites that it could possibly happen. But it doesn't mean that the fallopian tube is the only location where an ectopic pregnancy can happen. So now that our female patient has become pregnant, let's talk about what her body would endure over the next 9 months. Starting off with day 12. So at day 12, the amniotic sac is fully formed. It's responsible for the protection of the fetus. It's filled with amniotic fluid. At day 14, the placenta, a disc-like organ composed of fetal and maternal tissue, is responsible for the nutrient gas exchange between mother and fetus. At day 21, the umbilical cord is fully formed. It's responsible for the oxygenated blood towards the fetus. The arteries return the blood from the fetus back to the mother. Now, here are some typical maternal changes that will happen. So, the kidney volume will increase by 30%. This is a likelihood of the increased chance of UTIs. The mother will have an increased blood volume of 30 to 50%, so from about 8 pints to about 11-12 pints. The cardiac output increases by 30 to 50%. The diaphragm shifts upwards and displaces the heart. This can cause respiratory distress with physical exertion. It can cause systolic and diastolic murmurs. Heart rate gradually increases by 20 beats per minute or more. This can cause ectopic beats on the EKG. So now that we've gotten through the conception area, the conception era, and now that she's growing the fetus, let's talk about pre-delivery. So our main objective is to evaluate our pregnant patient and determine if we stay in play or load and glue. So let's talk about gravidity and parity. So we're going to be calculating a GPA, if you've ever heard it called that. So a prima gravida is a pregnant person pregnant for the first time. Primipara has had only one delivery. Multigravida is 2 or more. Multipara, 2 or more deliveries. Grand multipara is more than 5 deliveries, and nullipara is never delivered at all. So keeping that in mind, we have a couple examples. So here are 4 examples that we can use to calculate a GPA. So looking at example A, we have a woman with 4 pregnancies, but has only carried one to term. The 3 others ended in a miscarriage. So GPA, right? So gravida. So she's had 4 pregnancies, so G4, but only carried 1 to term. So para 1, and has 3 miscarriages, so A3. So her GPA is G4P1A3. All right, let's look at example B. This woman has had 2 pregnancies, but carried only one to term and the other in a miscarriage. So her GPA is her gravida is 2. She's had 2 pregnancies. She's only carried one to term, so P1, and she's had 1 miscarriage, so A1. So G2, P1, A1. Look at example C. A woman with twins born at 32 weeks, a history of 2 miscarriages at 11 and 9 weeks, and currently pregnant. So she's been pregnant 3 times, and she has carried 2. She has had 2 born at 32 weeks, so P2, with 2 abortions, 8-2. Example D, a woman who is pregnant with twins has 2 other children and previously carried at 6 weeks. So her GPA will be a G4 since she is pregnant with twins, 2 other children, and she previously miscarried at 6 weeks. So G4P2A0. So now we've learned how to calculate GPAs. Let's talk about the stages of labor or delivery. So stage 1 is dilation, regular contractions. It lasts from 12 to 16 hours if it's a premipara. So going back, a premipara has had only 1 delivery. And can last from 5 to 7 hours if they're multipara. Multipara is whenever there are 2 or more deliveries. Stage 2 is the expulsion. So baby has entered the birth canal. It can last up to 80 minutes for a premipara patient and 30 minutes for a multipara patient. Stage 3 is the placenta delivery. Time between birth and after birth. Depending on the patient, time can be 5 minutes to 30 minutes. So why is all this important? So if you have a patient who is premipara, they've only delivered once, or someone who is nullipara who has never delivered, and we get called out for a possible pregnancy call, it's important to remember what stage of labor and what the stages of labor actually look like and how long they can last. So as we can see, there's some type of trend with the multipara and premipara patients. For premipara patients, it typically takes a little bit longer, of course, to actually deliver the baby. Whereas the multipara patients who have delivered more than once, actually more than twice, it may not take that long to deliver. So by the time that they feel like they're in labor, by the time that we get there, they could already be in stage 2 or stage 3 of labor. So here's a scenario. So we're dispatched to a 23-year-old female who's complaining of lower abdominal and back pain. She advises dispatch she is currently 38 weeks pregnant and thinks she's in labor. She's in so much pain she can't speak anymore and hangs up the phone. That's our scenario. So let's talk about patient assessment. So a critical step. So we're entering our patient assessment, so let's remember to be respectful. We interact with different cultures, different races, different experiences when it comes to pregnancy and childbirth. Let's also remember to communicate. It doesn't matter if it's their first baby or their 5th baby. That's their baby. They want to know what's happening, and especially if there's something wrong with the baby. So remember to communicate. And lastly, let's remember to include. This is supposed to be a magical experience with rainbows and sparkle dust. So when they meet their newborn, they'll wait 9 months, some even years, to hear their baby's first cry and even enjoy their baby's first birthday. So remember to include the mom, even though it's not the experience that she wanted. She probably wanted a more natural birth in a hospital that is a more controlled environment instead of a back of an ambulance or at home or by herself. So make sure you remember to be respectful, remember to communicate, and remember to include. So going back to our patient, she's 23 years old. And she's complaining of lower abdominal pain and back pain. And she's 38 weeks pregnant. Okay? So let's determine if our patient is actually in true labor. So while assessing the patient for vital signs, and symptoms of labor, let's ask the right questions, right? So let's get her full name and age for the receiving facility, and also we need it for our reports, right? So she's 23 years old. She's a female, and her name is, we're going to call her Jane Doe. Alright, what is her expected due date? She advises dispatch that she's 38 weeks pregnant. So she's expected to be due in another 2 weeks. Is this her first pregnancy? Whenever you ask her, this is actually her 4th pregnancy. She has 2 living children, 1 stillborn. Okay? So based off of that information already, is she a primipara or a multipara patient? She's a multipara patient. And going back to what I just said, for the patients who have delivered more than twice, they are not expected to labor long. Okay. And from the information, it also tells me that she has had 1 stillborn. So that there's possibility that there was some type of complications during delivery. That I don't want to be worried about it, but I would definitely consider it in how I approach delivering her baby. You could further ask her more questions on that. Was there some type of cord issue? Was there a type of amniotic fluid issue? Did she just wait too long? Well, did she labor too long? Did she not receive any type of prenatal care? Did she not even know that she was pregnant? Those are also a lot of questions that you could possibly ask. Alright. Our next question. Has she had any prenatal care during this pregnancy? That's a very important question to ask, especially in these rural areas. Especially, I know wherever I work, there's not a lot of prenatal care, and I've had a lot of patients who have not received any kind of prenatal care during the 9 months. 1, because it's not offered to them, and then 2, they can't afford it, and then 3, they just don't want to do it, or they don't care to do it either. When did her labor pains start? Going back to the other question, has she had prenatal care during her pregnancy? Whenever you ask her this question, she says yes. And she's considered to be high risk. Okay, you could ask her more about it. Why is she particularly considered to be high risk? Is this because of the location of the baby? When I say location, is the baby in normal position, or is the baby in a breech position? Is there a low amount of amniotic fluid? Another thing they can look at is the location of the placenta. Is it anterior or is it posterior placenta position? Meaning, if it is if it's an anterior placenta, that means it's more frontal, and that a lot of times when patients deliver with the anterior placenta, the placenta is going to come first before the baby, and there could be complications during that. What's another question that could possibly can be considered high risk? Was there a low birth weight or low expected birth weight? Or is the baby too big? Could be something physiologically with the mother pelvis. Is her pelvis wide or narrow? The baby's head circumference, is it too big for her to deliver? Some more questions you could possibly ask her was, did she have a scheduled C-section? or was they expecting for her to deliver natural in a more, what I say, was she scheduled for the induction? Was she scheduled to be induced in a more natural, controlled environment in front of doctors? Let's see. Number 5. When did labor pains start? So when you ask her this question, it's currently like 9 o'clock. And contractions started at 2 p.m. So going back to the previous stages of labor and delivery, a mother who is a multi-payer patient, the baby has entered the birth canal, right? Can typically take up to 30 minutes. Alright, so it took you 30 minutes to get there. Alright, so has there been a rush of water or is there a bloody show present? Whenever you ask her this question, she tells you that her water broke just before she called, which was 30 minutes ago. Because it's a very rural area and you have to drive 30 minutes to her location. Alright. Does the patient feel the urge to push? This is a very important question. Because she tells you that she feels like she has to push. Now, you need to start making some moves in your head. You need to start making some decisions about what's your next step or next, point in your plan. You should already have a plan in your head. If she feels like she has to push, another question. Does the patient feel the need to have a bowel movement? If the answer is yes, never allow the patient who you feel is in active labor to use the toilet. I'll go more into that. But at this point, we kind of feel like she is in active labor. So, I feel like she's in active labor. You should also be feeling the same thing. And at this point, you need to start making decisions. Are you going to stay in play? Or are you going to load and go? Do you actually think that you could get her onto the back of your ambulance in enough time into the hospital to deliver the baby? I say no. If she already feels like she has the urge to push, then she's more likely going to push the baby out in the next 5 minutes. I think that you should stay in play. Go ahead and prepare Jane Doe in a comfortable position and prepare for an immediate or imminent delivery. So at this point, you should already have your OB kit. I know for me, every time I have a pregnancy call, I just want to go ahead and grab it just in case. So you should already have your OB kit. You should already preparing for imminent delivery. Because more likely she's going to have a baby in the next 5 minutes. Alright, so delivery. So our delivery objective is that our main objective is to prevent delivery complications for both the mother and the baby. Alright. Alright, so delivery procedures. We've established that Jane Doe is in active labor. She's going to be delivering this baby in the next 5 minutes. You don't want to try to get her on the back of your ambulance. You're going to just go ahead and have Jane Doe lay back on her back in a comfortable position. Get your OB kit out and ready, open. And we're going to prepare for delivery. Alright. So delivery procedures. Number 1 is that we're going to grab the OB kit. We're going to apply our sterile gloves, a mask, gown, eye protection for infection control precautions because of bloodborne pathogens. We're going to have the mother lie with her knees drawn up and spread apart. We're going to try to elevate her buttocks with blankets or pillows if we can. We're going to create a sterile field around the vaginal opening with sterile towels or paper barriers. As the baby's head is crowning, support it with gentle pressure and gently support the head during delivery to avoid explosive birth and prevent injury. If the amniotic sac has already broken, use a clamp to Use a clamp to puncture the sac and push it away from the infant's head and mouth as they appear. Now, Note the color and the character of the amniotic fluid. Normal is clear or straw. Meconium is dark brown or black substance. It could indicate if the infant has swallowed any kind of meconium. So step 6, as the infant's head is being born, determine if the umbilical cord is wrapped around the infant's neck. If the cord is too tight to slip the cord over the head, apply the umbilical cord clamps and cut the cord. After the head is born, support the head. Suction the mouth 2 or 3 times and the nostrils. Because babies are mouth breathers, they're going to breathe with their reflexes to open and breathe through the mouth first. So if they have any type of mucus, meconium, or amniotic fluid in their mouth, and they take that big deep breath, then they're going to aspirate all of that fluid. Alright, so we're going to encourage the mother to push while supporting the baby's head as it delivers. Now be cautioned, the baby is very slippery. Step number 9. To assist in delivery of the baby, if the shoulder is stuck, apply gentle downward pressure on the shoulders while continuing to deliver the newborn's head. Now your baby is born. Now what do? Alright, so step 10, we're going to wipe the blood and mucus from the mouth and nose with sterile gauze. We're going to suction the mouth continuously and nose again and stimulate the newborn to breathe with vigorously rubbing with a towel or a blanket. Once the umbilical cord has stopped pulsating, we're going to clamp the cord by placing a clamp approximately 8 to 10 inches from the baby. Place a second clamp approximately 2 to 4 inches from the first, then cut the cord between the clamps. Now, do not cut or clamp a cord that is still pulsating. And do not tie, clamp, or cut an umbilical cord on the baby who is not breathing unless it's around the neck. Okay. Now, we're going to resuction the baby's mouth and nostrils. We're going to dry and wrap the baby in a warm blanket and cover its head. We're going to place the newborn on its side to facilitate drainage of the nasal and oral secretions. And we're going to perform our Apgar score. Okay. So now that our baby is born, Mom, we're going to assume that she's okay. Jane Doe is okay. We're going to go into our post-delivery phase. So our main objective is to observe Jane Doe and her baby. We're going to observe and demonstrate we're going to be competent to manage any kind of complications while providing empathy and compassion for our patients. Sorry. So now that the baby is born, let's make sure that the baby is okay. So now we have to perform an Apgar score. It's very critical that we do this to assess whether or not the baby is improving or declining. So an Apgar scoring system, it helps identify babies that may need further care. It's checked at 1 minute and 5 minutes after birth. A score between 7 and 10 is considered to be normal. Anything from between 4 and 6 is abnormal and indicates that the baby needs some type of breathing assistance. A score below 4 means that the life-saving resuscitation measures are needed. So, let's look at some examples so you can get the hang of it. So, example number 1, Apgar assessment. The baby is pink all over. Heart rate is 95. Is highly irritated when you mess with him. Move around actively with good muscle tone. And is crying his heart out and breathing well. What do you document the Apgar score to be here? Okay. So let's break it down by section. So appearance. Skin color. We said the baby has a pink color, so that baby gets the score 2. Pulse rate. The heart rate is between 60 and 100. We said that the heart rate is 95, so gets a 1 because it's below 100. Grimace. Very, very irritated. So that's actually good. So we're going to get 2. Activity has good, moving the arms very good with good muscle tone. So baby gets a 2. Respiration. Whenever you stimulate, it has a very strong cry, a vigorous cry, so baby gets a 2. So the total APGAR score for this newborn will be a 9. All right. After we have our APGAR score, we should get a set of vital signs on this baby. I would recommend taking the vital signs at every 5 minutes to really assess the trend. So for a neonate, the normal vital signs for a newborn is that the baby should be able to maintain a stable body temperature in a normal room, typically between 96.8 and 99.5. If it's below that, baby should be wrapped up in a warm blanket. Can also put the baby on the mother's chest for skin-to-skin contact. Another thing we carry is a mylar blanket. The big aluminum foil blanket could wrap the baby in that. Pulse rate. So we check the pulse rate at the brachial artery on either arm. That's just above the forearm. And the pulse rate should be normally between 120 and 160 beats per minute. Alright, so breathing rate. Breathing rate should be 30 to 60 breaths per minute. So newborn resuscitation, the breathing effort. If the breathing is shallow, slow, or absent, provide artificial ventilations. You can do this by BVM, you can do this, I would do this by BVM if they're shallow and slow. 60 breaths per minute. So 30 to 60 breaths per minute. If anything is below that, it's considered to be slow. Reassess after 30 seconds. If no improvement, continue artificial ventilations and reassessments. Heart rate. If it's less than 100 beats per minute, provide artificial ventilations as stated above. If the heart rate is less than 60 beats per minute and not responding to any kind of bag valve mask, assisted ventilations, artificial ventilations, begin CPR and call for ALS assistance. Okay, so now that we hypothetically say that the baby is not doing so great, is declining and has a heart rate of, we'll say 50, and is not responding to any type of artificial ventilation after a couple minutes, after 30 seconds, then I would make the decision to go ahead and start CPR on the neonate. So I'm going to walk you step by step through infant CPR. Okay? So step number 1, we're going to place the baby on their back on a firm, flat surface. Hang on. So remember going back a couple of slides, I said be respectful, remember to communicate, remember to include. So if this is a mother who is worried about her baby, then make sure that you communicate to her everything that is going on, especially if you're about to do CPR on her baby who is just born. Okay? So make sure that you provide sympathy and empathy to the mother, stating that, hey, baby's not doing good so far. So I'm going to provide a little bit of help for baby to support him or her, either or. And just explain that, hey, baby was breathing slow. I started providing some artificial ventilations, or say I started breathing or supporting the baby by breathing with him with a BVM. And then you reassess at 30 seconds and baby's still not improving, and that the heart rate was a little slower than what you wanted. So you're going to start CPR on the neonate. So make sure you communicate and include and be respectful of the mother. Alright, so place the baby on their back on a firm, flat surface. We're going to place both thumbs side by side, on the center of the baby's chest, just below the nipple line. We're going to give 30 compressions at a 1 inch deep, at 1.5 inch depth at a rate of 100 and 120 per minute. We're going to give 2 breaths. We do this by performing a head tilt chin lift and give 1 breath. 2 breaths, sorry. 1 breath and then another breath. We're going to make sure that chest rises and falls. For neonates, we see that there is air on the sides whenever we're giving ventilations. Also, babies have big heads. You may need to put some type of blanket on their back between their shoulder blades, elevate to try to minimize that space. We're going to continue giving sets of 30 compressions and 2 breaths. We're going to place the AED or our defibrillator, our life pack, manual AED, and we're going to continue CPR. At this point, make sure you call for help. If not, you're not going to get any. Alright? So, if there's types, let's talk about mother. Some post-delivery procedures for the mother. Remember to keep mother and baby safe and warm. So we're going to place the wrapped baby on the mother's chest for warmth while transporting them to the nearest facility. We're going to prepare for delivery of the placenta about 20 minutes after the newborn is delivered. Remember, the mother may be more serious patient. Postpartum hemorrhage can kill. So going back, during pregnancy, the patient has gained about 30 to 50% more blood volume. So additionally, another 3 pints. That is a lot of blood. So after delivery, the mother could bleed out. So we're going to provide fundal massage. So we're going to take our fist. First off, please tell the patient that it's going to hurt. It's just going to hurt. We're going to take our fist, alright, and we're going to put it in the center of the mother's stomach, or on the lower abdomen part, and we're going to massage the abdomen. We're going to put, basically, it's like we're kneading dough. It's going to hurt. This can help postpartum bleeding. If the fundal massage fails to slow or stop the bleeding, request ALS assistance or backup. Alright, and that's the end of my presentation.